So good morning, ladies and gentlemen. It's my pleasure to welcome you to the third edition of TogetherVT meeting, which started just before COVID, and we had one edition in Milan and the other one in Bordeaux, and now it's a turn for Prague. I hope that within next few minutes or hours there will be more people, because we have a fair number of registered people, and we have also online registrations, about 100 registered online, because this is a hybrid meeting. So I hope that you will enjoy the program. Please use the time to discuss with the faculty, and don't be shy to ask any questions. And it's also my pleasure to welcome distinguished faculty members from all over the world. And I'm very happy that they accepted our invitation and came to Prague. And now I pass the word to Paolo Della Bella, who is one of the, let's say, founding fathers of this meeting. So, Paolo, just a few words for the beginning.
Thank you. Good morning, everybody. And first of all, thanks to you, Josef, for organizing this. As usually, everything is very nice. It's really a pleasure for me to be here again. As you know, TogetherVT was originated by a group of European physicians that really love VT, including, of course, Josef, Thomas, Deneke, Pierre Jais, Katja Zeppenfeld, and we are very happy that Frank Marchlinski joined with us in the steering committee, in the organizing committee of this meeting. I think that we really need a VT meeting to put together the experiences, and we try to do it every year to share science and to also disseminate education among younger and enthusiastic colleagues. So I think that I would kind of toast to a long life to TogetherVT, and of course I'm very happy to be here with friends, and thanks again to Josef for organizing this. I think that we have a very packed program that will start off, I guess now, correct? With Thomas, Deneke and Josef as chairs of the first session. So I think that without any further delay, I would start with that.
Thank you, Paolo, and it's my pleasure to invite the first speaker of this symposium, and it's Thomas Deneke, one of the members of the program committee and organizing committee. And we will talk about how to differentiate between right and left ventricular outflow tract in idiopathic VTs, because ECG, as is the title of this session, remains the main tool to determine where to go, whether it's idiopathic or whether it's a structural disease VT. So, Thomas, please.
Thank you, Josef, for the kind invitation and for organizing this third edition of TogetherVT, and thank you, Paolo, for also the introductory words. So it's a great pleasure to be here and focus on EKG. And can you put up my slides? Just to, and I will talk about the potential of the ECG to differentiate between right and left outflow tract in idiopathic VT, or PVC. So, as you may know, idiopathic VTs are growing. It's an increasing number of patients, and we have some robust data for that as well. As you can see here, it's VT to a lesser degree than it's PVC, but it's a lot of patients that come to us with symptomatic PVCs that need to be treated. Historically, it was assumed that approximately 80% of the idiopathic outflow tract VTs and PVCs come from the right ventricular outflow tract. I'm not so sure about that anymore, and would say it has turned either to a 70-30 or a 60-40 most probably, and it really, in my institution, it's 50-50. So that means it's very important to determine the site of origin before starting the procedure, to guide access, to counsel the patient about the effectiveness and the potential risks. And as you may know, if you have an LVOT, ventricular arrhythmia, it is harder to ablate. It has a lower success rate. It is associated with a higher complication rate. And left ventricular arrhythmias and PVCs more commonly lead to PVC-induced cardiomyopathy. And having said that, there are multiple, and I've just included 9 out of those algorithms out there who will help us to differentiate right from left. So it's really a lot of complex algorithms, calculations. I know many of the faculty that are here have also published on this, and I will try to summarize what I think is essential in the early beginning to start off with this problem. And when you look at all these algorithms, you have at least seen one patient who didn't fit all these algorithms. So it's always good to have a back plan. So the surface ECG and outflow tract ventricular arrhythmias is complex because the anatomy is complex. As you may know, the right ventricular outflow tract and the pulmonic valve are at a different position compared to the aortic valve, the left ventricular outflow tract, and the aorta. So the right ventricular outflow tract is actually anterior, but to some degree leftward compared to the left ventricular outflow tract, which is more posterior, but rightward directed. And it is actually more entangling in each other, so this can make ECG differentiation really hard. So outflow tract is usually QRS positive in 2, 3 and AVF, and negative in AVR and AVL, which means it's coming from above, which is the basic concept of EKG in idiopathic PVCs. Now, lead V1 can be negative in RVOT or is negative in RVOT, especially if it's posterior or above the pulmonic valve, the site of origin. You may have small R waves. That will come to that later on. If you have an R wave in lead V1, in the LVOT site of origin, you usually have an R wave in V1. RS transition is a very important tool to differentiate between right and left ventricular outflow tract. And just looking through the literature, usually what you find is if you have an RS transition at V4 or later, it's most likely RVOT. If you have the RS transition in V2 or earlier, it's most likely LVOT. So what we're trying to differentiate then is really what happens if we have the RS transition in V3. And lead 1 can be negative depending on the exact anatomy and location of the site of origin. So if you have a negative lead 1, it's usually anterior RVOT, LCC, or aortic mitral continuity, and it's positive in the septal RVOT or the right coronary cusp. In an ideal heart, let me put it that way. So in the ideal heart, it looks like this. And this is, I think, once again, representing how complex anatomy is and what we can learn from that. As you see, if we have an RS transition in V3, I indicated that this is usually this region here. Anatomically, it's the septal RVOT or the right coronary cusp, sometimes also the left coronary cusp. So this is very, very closely spaced together, and we will come to some exceptions to this rule as well, because there may be some conducting fibers in between the septum or through the septum of the outflow tract. So in these circumstances, as you can see, it is so close, it may not be the EKG may not be the ideal tool to differentiate the origin, comparing or differentiating septal RVOT or posterior. It used to be more posterior, now it's more septal, the definition, but I guess both allude to the same region compared to the RCC, and you can see how close this is together. And the more posterior though you get, and this is just some hints from lead V1, the more posterior you get in the site of origin, the more likely you're having an R wave, which means in this situation where we are at, if we talk about this specific region, either septal or posterior RVOT or RCC, there may be a slight difference in regard to the height of the R wave in lead V1 being slightly smaller in 2 compared to in the posterior RVOT site of origin compared to the aortic sinus site of origin. So, having said that, if you look at the distribution of the site of origin of a PVC and look at the R wave transition, which is nothing else than the RS transition zone, you can see that if you have your R wave transition in V3, it's more likely to be RVOT than it's actually LVOT. But also in the V2 transition, there are some cases of RVOT PVCs, as well as if you have the RS transition in V4. There's also a slight percentage of LVOT or ascending aorta or right coronary cusp PVCs included. And why is that? Because we're not living in an ideal world. And one of the most things that alludes to this is actually cardiac rotation. You may know that cardiac rotation can be identified from the sinus rhythm RS transition zone. So in 40% of cases, if you look at a large population, you usually have no rotation of the heart in this matter, but more than 50% of the cases you have a counterclockwise rotation, which means that your RS transition is not as usual in V3 to V4, but is earlier. A clockwise rotation, on the other hand, and this is important, is rare, but it is in larger population-based studies is related to a higher incidence of cardiovascular mortality in the general population. So the RS transition must be corrected for cardiac rotation if you want to differentiate RVOT from LVOT. And there are different ways to do it. One important message is, I think, if the RS transition in sinus rhythm is earlier than in your PVC or is later in your PVC compared to sinus rhythm, it's most probably RVOT. But if you have, like in over 50% of the patients, a counterclockwise rotation of the heart, then your RS transition, even with the right ventricular outflow tract PVC, can be earlier than V3. You can correct this using an index. This is the transition zone index, which looks at the transition in the PVC and subtracts the transition zone in sinus rhythm. And if you end up with a positive value, it's more likely RVOT. So this is more or less what is indicated here. But if you have a negative, then it may be the left ventricular outflow tract. So it really depends on rotation. And I think, Frank, your group also published on the V2 transition ratio, which is complex calculation, but pretty much indicates, depending on the V2 pattern of R and S waves, where this may come from. Another important point that may lead to misinterpretation of the ECG is actually preferential conduction. I already indicated that there may be some myocardial fibers across the outflow tract septum, which in LVOT origins, in 1/4 of them, may lead to a preferential conduction and exit at the right ventricular outflow tract. So that means you have your focus in the left coronary cusp or the aorta, but you have an EKG appearance suggesting RVOT site of origin. This has led to some of the findings that have later been presented, indicating that if you ablate at this breakout point, you may create a shift of PVC QRS morphology, like in this example. So ablating in the RVOT, if you have a preferential conduction to the RVOT, but have a focus on the left, will lead to a different QRS morphology and a leftward shift of your PVC site of origin, which I guess most of you have already seen once in a while. It's not often, but it's around 4% of the outflow tract PVCs that we see may have this preferential conduction. Let me do the last 3 slides on a case that I just wanted to present to you. So this is, I already indicated, an RVOT PVC. If you look at the QRS morphology, and we will come to that later, you have an RS transition in V3, suggesting that it may either be left or right. If you look at most of the indices that indicate if it's left or right, all of them actually point towards the left ventricular outflow tract. So transition zone index would be the transition zone in between V2 to V3 in the PVC minus the transition in V5 in the sinus rhythm, indicating that it would be negative, implementing that it would be a left ventricular outflow tract arrhythmia. But what you can see here is that actually you have a clockwise rotation of the heart, which makes these things kind of tough. Why is it still an RVOT PVC? And I think that, and this is data from Magdi Saba in London, who looked at the variability of the PVC burden on a 24-hour Holter EKG. And interestingly, and this may be related to autonomic tone in the RVOT compared to the LVOT, if you have a high variability, or if you identify hours in your Holter where you have less than 50 PVCs, this is a very strong indicator that this is an RVOT PVC, as in this case, where we actually had times during the nighttime where this patient did not have a single PVC, indicating that this is an RVOT case. And actually, the best pace map match, the earliest activation, and the effective ablation site all were on the RVOT septum. So, in conclusion, all the algorithms that I indicated to you are hampered by 2 important things. They usually have a low number of patients. They mostly rely on pace mapping, which implies the risk of far field capture and the site of effective ablation. On the other hand, the application of these algorithms may also be hampered by if you have a change in precordial lead position, if you have abnormal thoracic anatomy, cardiac rotation, preferential conduction, we discussed that, away from the site of origin. So if you have an outflow tract ventricular arrhythmia and your RS transition is earlier than V2, it's most likely LVOT. If it's later than V4, it's most likely RVOT, but with some exemptions, and I think this is related to RS transition in V3, but also holds true for some of the V2 transitions or V4 transitions. Look for the sinus rhythm transition zone because this may indicate if you have a rotation of the heart. If you have a later transition, then in sinus rhythm on your PVC, it's most likely septal RVOT if it's V3 transition zone. But if you have a high hourly variability, and please look at that in your EKGs because this is interesting. If you have a minimum number of PVCs of less than 50 per hour, it's most likely RVOT. Thank you very much.
Thank you, Thomas. We leave discussion for the end of this session because it deals with ECG as a tool, as I mentioned. And it's my pleasure to invite Frank Marchlinski, who will talk about the localization of the substrate and VT exit from reentrant circuit in ischemic and non-ischemic heart disease. So this is even more complex than idiopathic. And yeah. So Frank, please. So you will cover the last one, then we will start discussion.
Thank you, Joseph. Thank you to the co-directors for inviting me to participate in this symposium and to represent the U.S. in this event. So, and Joseph, thank you especially for the organization in your hometown here.
It's interesting how you can put that up as I have it on my computer here and it's not hooked up anymore.
Magic.
So this is magic.
EP is magic.
Some remaining
remaining
hooked in
images.
the system.
I can't do a better job than Thomas, so I'm going to not pretend. When my slides become available, I'm going to talk about how you use the 12-lead ECG to tell where to map and identify the substrate and where your ventricular tachycardia is based on the 12-lead ECG in sinus rhythm and in the ventricular tachycardia.
Yeah, it's working.
All we need is on the big screen. Perfect, thank you. Just tell them slideshow, right? Yeah.
No, something.
Here it comes.
There it is.
Okay, so again, how do you localize the substrate and VT exit from reentrant circuit in ischemic and non-ischemic disease? Here's a list of disclosures. So first I'm going to talk about the 12-lead ECG in sinus rhythm to localize the substrate. We'll start with low-hanging fruit. In setting of an acute infarction, we have an obvious 12-lead ECG showing an anterior infarction, and at the time of substrate mapping, we might anticipate seeing a large scar in the apical septal region of the ventricle. In the patients with a big inferior Q-wave scar on the ECG, you'd anticipate low voltage areas, the basal inferior aspect of the left ventricle. So that's pretty obvious and straightforward. We've been doing that for years. In non-ischemic, it's usually more subtle. This is one exception because we've been taught that probably since medical school that in patients with arrhythmogenic right ventricular cardiomyopathy, they have characteristic ECG changes in sinus rhythm with T-wave inversions and delayed activation in the anterior precordial leads, including the presence of epsilon waves that predict the presence of an extensive anterior RV free wall, low voltage area, and substrate for ventricular arrhythmias. What we've come to recognize, however, is that in many patients who fulfill task force criteria for arrhythmogenic right ventricular cardiomyopathy, they have more subtle forms in terms of the disease substrate. Sometimes it wraps around only the bottom of the tricuspid valve annulus, and instead of looking at the anterior precordial leads, if you look at the inferior leads, you begin to see the same type of activation delay, terminal delay, and epsilon-like activity in the inferior leads. in some smaller group of patients, about 20%, you may see low voltage areas that only surround the RV outflow tract area free wall around the pulmonic valve. And in those patients, lead AVR assessment may identify, again, these terminal squiggles that represent delayed activation, consistent with this delayed activation in the, towards the right shoulder and the pulmonic valve. Now, okay. I think this version is not going to be the version with the, okay, but it's okay. We don't need to. We don't need to. It's fine. So listen, we've looked at non-ischemic left ventricular cardiomyopathy for a number of years. And first we recognize that the substrate commonly is inferolateral, lateral, anterolateral, so a lateral free wall location, not uncommonly more dominant on the epicardium rather than the endocardium. Imaging helping us identify the location of this substrate. And knowing this as the substrate, we could have the opportunity to go back and look at the 12-lead ECG in sinus rhythm and determine whether in these patients with left ventricular non-ischemic cardiomyopathy and these basal lateral scars, whether the sinus rhythm ECG provided a clue to the presence of this substrate. This is work from Wendy Zoe when she was with us at Penn, comparing patients with ventricular tachycardia and this typical basal lateral scar in the setting of ventricular tachycardia compared to those patients with non-ischemic cardiomyopathy without ventricular tachycardia. And what she demonstrated through a systematic analysis of a number of ECG features, that the dominant ECG feature that helped us distinguish patients with VT versus no VT in this setting was the presence of an R wave in V1 that is greater than 0.15 millivolts and an S wave in V6 greater than 0.15 millivolts. It's consistent with something that one might think about a small posterior infarct, in this case frequently involving a superficial layer of the epicardium and creating these subtle but significant ECG changes. Just look at the top row, the R wave in the patients with VT versus those without VT in V1, and the S wave in V6 with VT compared to the patients with non-ischemic cardiomyopathy and no VT in the bottom row in V6. We went on to look at patients with VT in the setting of a basal lateral scar associated with non-ischemic cardiomyopathy versus a typical posterior inferior myocardial infarction, and documented 3 criteria when used in an algorithm help predict the presence of a non-ischemic process versus ischemic infarct very reliably, specifically QRS fragmentation in lateral leads, more common with the non-ischemic cardiomyopathy, the absence of an associated Q wave in the inferior leads, non-ischemic cardiomyopathy, and then finally, again, the bigger S wave in V6 and a V6 S to R ratio greater than 25% being consistent. When used in a validation cohort, 93% of the patients predicted, accurately identified whether it was going to be non-ischemic versus ischemic in a sizable patient population. And why is this clinically important? Well, we know in pre-procedural planning, if it's a non-ischemic process, that more likely to need an epicardial approach versus an infarct-related scar, where endocardial ablation is typically all that's required. Here's a typical example: a 28-year-old, normal coronaries, depressed LV function, presents with this sinus rhythm ECG. We see again increase in R wave voltage in V1, S wave in V6, predicting without any imaging the presence of perhaps normal endocardial voltage and epicardial patchy scar with abnormal electrograms, and finally the MR imaging showing the epicardial scar producing these subtle but definitely present ECG changes. In addition to the typical basolateral scar, we know it took us a while to recognize this and a lot of epicardial mapping before we understood that many patients with non-ischemic cardiomyopathy end up with a mid-myocardial septal scar with normal endocardial bipolar voltage map, normal epicardial bipolar voltage map, but with the presence of a mid-myocardial scar responsible for multiple ventricular tachycardias. And work from Pierre's and Zeppenfeld and colleagues highlighted this important difference between basolateral scar and septal scar and emphasized the importance of trying to bin these two forms of non-ischemic cardiomyopathy that are responsible for VT into the septal versus not the basolateral bin, so we can look at subtle information from the ECG and imaging to help anticipate what to expect in the EP laboratory at the time of mapping and ablation of ventricular arrhythmias. This is from work from Dr. Olleries, working in Dr. De Bella's lab, combined with the group from Maastricht, where they looked at 12-lead ECGs in patients with anteroseptal substrate and identified 4 ECG features that predicted with a high degree in sensitivity and specificity of an anteroseptal substrate, specifically alterations in the conduction. This is basal septal, affects the conduction system, so one might anticipate one ends up with ventricular paced rhythms, PR prolongation, QRS, interval prolongation, and conduction disturbances in patients with anteroseptal substrate, and also an R wave in V3, which is diminished, with V3 looking right under, or rather right over the ventricular septum. And in contrast, patients with basolateral substrate have a normal PR interval, typically less than 0.17, QRS diminished in the inferior leads in patients with VT, and occasional Q wave in the lateral wall. I would also suggest that looking at the R wave amplitude in V1 coupled with the S wave in V6 might further even enhance this high sensitivity and specificity when using ECGs to determine septal versus basolateral scar. This is additional work that we recently performed trying to determine whether the QRS amplitude and fragmentation in non-ischemic cardiomyopathy help to predict the presence and location of the VT substrate and origin, site of origin. The QRS amplitude in AVF appeared to be more common in the presence of ventricular tachycardia, probably indicating a more substantive scar that's responsible for VT in the patients with non-ischemic cardiomyopathy, and was uncommonly seen in patients without ventricular tachycardia. Fractionation in the QRS complex commonly seen in both groups, so it's not specific for the presence of ventricular tachycardia. However, fractionation did co-locate with voltage map abnormalities and MR abnormalities, so it's still worthwhile information to glean from the 12-lead ECG when you're thinking about where to start your detailed voltage mapping. Let's move on to talk about the 12-lead ECG during ventricular tachycardia and what it tells us. This is from pioneering work from Mark Josephson, and I suggest you read it. It's a true opus. This is a publication in Circulation, 15 pages long, 11 figures. It was a labor of love. These are single-lead ECGs. That's what we had from a strip chart recorder, and I was responsible for making most of those ECGs, not in interpreting where the VT was coming from. That was Mark's effort. But it's pioneering effort. I just want to refer you to this article because it was very important. It's a very nice piece. It took us, that publication was 1981. This is a publication in 1988. So you might say it took us 6 years to learn and develop the expertise that Mark had in looking at the ECG and identifying, importantly, with reentrant circuits, not where to ablate, but where to start mapping, where the VT exits the area of the circuit and begins to activate normal myocardium. So it gives you an idea of where to start mapping, but the isthmus is not determined by the ECG, it's determined by additional mapping during the procedure. But the 12-lead ECG is helpful to get us started. This was a blinded review of 182 VTs in 108 patients. We had 12 anatomic sites to apply the ECG information and designate based on the ECG where these VTs were exiting the ventricular arrhythmia circuit. And we used basic vector analysis. First, the common concept that in coronary disease, left bundle will be coming from the septum, right bundle more likely to be coming from the free wall, the frontal plane axis to tell us where it's coming from the top of the heart or the bottom of the heart, lead 1 to tell us whether it's septal or apical and free wall, and then the precordial leads to tell us whether it's basal versus apical. And in this analysis, we had 93% concordance. I'm always tease my colleagues Al and John Miller that Mark and I were 100% concordant, but the idea that we were able to identify using the ECG the anticipated exit from the ventricular arrhythmia circuit. This is a clinical example, a patient who comes to the lab with a history of a circumflex infarct, gets to your laboratory with this induced ventricular tachycardia. It's a right bundle, mid-precordial QRS transition in the precordial leads, more positive in 3 than 2, indicating a lateral location exiting towards the apical because of the precordial transition aspect of the scar. This is where we begin the mapping process, moving from the edge of the scar into the scar to identify a mid-myocardial potential, performing stimulation during the ventricular tachycardia to confirm our, with entrainment effort that our site is participating in the tachycardia circuit based on standard entrainment criteria, and of course terminating the ventricular tachycardia with energy application. The 12-lead ECG can also tell us in some situations where the anatomic substrate is, especially in patients who have, during sinus rhythm, evidence of left bundle branch block or paced QRS abnormality. Here in this clinical example, a patient with sinus rhythm, left bundle, during the ventricular tachycardia, Q waves during the ventricular tachycardia in V4, V5, consistent with a lateral scar that's present in this patient with a occlusion in probably either a big diagonal vessel or a big marginal vessel hidden on the sinus rhythm ECG, which showed left bundle branch block. The 12-lead ECG is also important in non-ischemic cardiomyopathy. We learned that most of the scar is basal, and so even in patients who present with a history of some coronary abnormalities, in this case, a mid-LAD stent, and yet clinically in the EP laboratory had these 3 induced ventricular tachycardias, all with R waves across most of the precordial leads, either in a right bundle or left bundle branch block QRS morphology. The V site of substrate abnormality in this patient with a mid-LAD stent is not in the apex of the heart associated with coronary disease. These VTs are typical for a patient with a non-ischemic cardiomyopathy that's basal. In fact, this is so important that when we see an apical QRS morphology, as shown in this slide, late QRS transition for this left bundle branch block morphology, in the setting of a non-ischemic cardiomyopathy, we should immediately think of the possibility that the patient has bundle branch reentry. Make sure we record from the His bundle area and identify and document the presence of a bundle branch reentrant circuit and allowing us to ablate the right bundle and eliminate the ventricular tachycardia. In addition, patients with multiple left bundle branch block QRS morphologies with a late precordial transition immediately in a patient with presents with a non-ischemic cardiomyopathy, we think about the possibility of an RV disease process, right ventricular cardiomyopathy, producing typical late precordial transition, extensive scar in the RV free wall. Finally, just two important points. One, in the patient with non-ischemic cardiomyopathy, that the clues on the ECG suggesting a septal origin are important. The fact that in patients with non-ischemic cardiomyopathy who have a septal VT, they frequently end up with paired VT morphologies. In this case, and in this example, a patient with two VTs, both with an inferior axis, one left bundle, the other right bundle, one exiting superior and rightward, the other superior and towards the top of the left ventricle, consistent with a septal substrate as the basis for both ventricular tachycardias. Another example of paired VTs on the bottom, this VT1 with a right bundle, inferior, slightly rightward axis, exiting superiorly, another VT from a septal substrate, VT2, left bundle, R waves are positive across the precordium, superior axis, exiting from the inferior aspect. The two ECG morphologies identifying a probable mid-septal substrate as the origin for both ventricular arrhythmias. So in summary, the sinus rhythm ECG is a powerful tool in ischemic cardiomyopathy, just looking at the presence of infarction. In non-ischemic cardiomyopathy, sometimes subtle clues in ARVC patients who with peritricuspid valve scar being identified in the inferior leads with some fractionation and conduction delay, peripulmonic valve scar by looking at AVR. In non-ischemic cardiomyopathy, basolateral scar being identified by the presence of a larger R wave in V1, S wave in V6, some fragmentation of the QRS in 1 and AVL, a normal PR interval, and low voltage in the inferior lead, specifically AVF, a septal scar being identified by evidence of conduction delay, and a low voltage that's decreased in V3. The VT ECG can be identified by looking at the 12-lead ECG. The exit can be identified by looking at the 12-lead ECG, again, using standard vector analysis, able to identify where most of the ventricular arrhythmias come from. I'll stop there, and thank you for your attention.
Thank you, Frank. Great presentation. And we move on to the next topic where the ECG may help. I always say the ECG does not lie, but does it always tell the truth? So Paolo Della Bella will talk about the ECG and when to go epicardial. Paolo, does it lie?
We'll see. Thank you for the introduction. Thank you again, Josef, for the program. Now, as much as I have enjoyed your presentation, Frank, there are some areas that really where the electrocardiogram provides only partial information. So I tried to share with you the doubts that we have, particularly when we have to take a tough decision, should we go epicardial, maybe first line, maybe after a failure. So there are many electrocardiographic criteria to define epicardial origin of ventricular tachycardia, but no single one allows a perfect prediction, and of course prediction is truly impossible. And also, at least in my view, I think that what the 12-lead can tell us is the identification of the exit without providing truly information on the true nature and location of the VT isthmus. This is the single paper that I like the most, not because you are here, but because I think it's a good guidance to identify epicardial VT in the setting of non-ischemic cardiomyopathy, because as you will see here is where really we have the toughest challenges. This paper, published by Dr. Valles, provides both morphologic and timing criteria to set a possible epicardial origin in a patient with non-ischemic dilated cardiomyopathy, including presence, absence of Q pattern in lead 1 during VT, presence, absence of Q pattern in the inferior leads, and a variety of timing criteria, including width of the QRS, difference in MDI, and which I think it's the most powerful among this, maximum deflection index, to assess the epicardial origin. As you see here, many of these criteria provide good specificity and sensitivity. The best, and I think the one that I try really to look for, is the presence, absence of a Q wave in lead 1 during VT, followed by the presence, absence of Q waves in the inferior leads, and of course, MDI, as said before. Anyhow, in the real world, I try to see how sometimes electrocardiographic guidance may be a challenge, and I would say kind of misleading. This is an example that we treated a couple of months ago, a patient, a gentleman of 75 years with a non-ischemic cardiomyopathy, actually prior myocarditis, residual ejection fraction 48, reasons for ablation requiring recurrent VTs in spite of amiodarone, and you see here the sinus rhythm electrocardiogram and the induced VT, pretty fast VT. You would call it a rightish bundle superior axis type VT. Now let's go on to the analysis of the items. On your right-hand side, the 12 lead, a little bit enlarged, on the left side, the criteria. Look at lead 1. There is no Q wave pattern, so this would point right away to an endocardial origin. On the other hand, there is Q pattern lead 2 and 3 that would, as said, exclude the epicardial origin. Width of the QRS, all in all, 165, MDI 0.53. So all these would actually tell you just go transeptal and do your endocardial ablation. According to our own criteria that I would like to share with you and discuss later on, as the patient had been labeled as myocarditis, we nevertheless decided to go first-line epicardial. And it took a while to define this small area of scar abutting from the AV groove towards the septum and the left side of the inferior wall of the epicardial ventricle, left ventricle. And more importantly, within this area, you see here, even more basally located, a small area of substantial conduction delay with an area of double potentials that you see here. Now, the match of this area to the VT is kind of doubtful because you would expect prominent and consistent R wave through the epicardial leads if your VT were to exit from here. But actually, this is what we had. And you see here, the late potentials were originated because of an area of conduction block that I would say we found here. You see this green line together with an area of conduction delay. So all in all, it brings to these late potentials that we were able to record epicardially. During VT, you see here nice diastolic activity at this site. Probably on the Prague tracing, you see them even better. We are able actually to track completely the diastolic interval starting from this long-lasting electrogram that starts from mid-diastole joins to the QRS, but also here you see this earlier, I would call them entry potentials, followed by this very low amplitude, enabling us to cover almost entirely the diastolic cycle of the VT here. This is the propagation pattern of this VT. You see here, actually the reentry occurs within this very small green circle, which is kind of a little bit more anterior to the area of late potentials, so do not always the reentry pattern collocate with the late potentials. You see here the green circle kind of identifies the junction between entry and mid-isthmus. And this is actually where we decided to apply current with immediate termination of the VT after 3 seconds. And you see here the recording of the electrogram of the ablation site. The color code here identifies actually green and yellow are kind of mid-diastolic events in this case. And the ablation was carried out completely epicardially, proving complete elimination and remap, as you see here, of any abnormal activity together with prevention of VT inducibility. So that was kind of a straightforward epicardial only case. Things are not always that easy. And that is why I really felt it was important to add this notice. What is the 12-lead electrocardiogram telling you, the exit site? Is it telling you the true 3D nature of the reentry? That is kind of doubtful. So let's move to the next case. It's, again, I would call it a full-blown picture of an anthology of the epicardial criteria, starting from the etiology, non-ischemic, Q pattern, lead 1, as you see, wide, broad complexes in V1 through V6, very slow upstroke, delta-like, as Professor Wellens was happy to call it. So let's go epicardially. We nevertheless started endocardially because we were kind of hunting this. I'm sorry you don't probably see it very well, but you see here isolated diastolic potentials during VT, the one that I'm pointing with the arrow, anterior basal area of the left ventricle endocardially. VT termination, followed by continuous induction, and always very light, very nice mid-diastolic potentials until I took the decision to take epicardial stack, went here, and as you see here on the left, a low voltage area, just partially covered by the left atrial appendage, and again, late potentials. How did we get that? It's a motion movie that shows you how quick it is to identify areas of conduction delay with multi-electrode mapping, and you see it here, a line of double potentials, and that slide also shows you that this was actually mirroring the sites of endocardial ablation. We had 11 millimeters of distance in between. This is what happened during VT. We started at VT induction, placing the mapping catheter at areas of late potentials, then shifting from recording during sinus rhythm to activation mapping during VT. As you see here, we tried to really take the diastolic interval only, so everything that is color-coded white and purple, forget it. Entry events, so early third of the diastole, red and yellow. Then we have green, mid-diastole, light blue, dark blue, exit. You see here, actually, and you will see it even later, what we were able to catch during VT is only early activity during diastole, so we call it early events. So we decided to shift during that VT that was, by the way, not very well tolerated, so it took us about 1 minute to do that. Ablation catheter now introduced at the site of mapping, where mapping had kind of shown entrance to mid-isthmus event. You see the electrogram recorded by the ablation catheter is kind of poor. So we decided to rely on the findings of multi-electrode mapping current on now. It takes about, as you can see, 10 seconds to get a change of the VT morphology into a more intermediate axis, just the time to put it on the recording screen, go on, and keep going with ablation at the same site until you get termination of 15 seconds, and that was it for the day. So VT it actually disappeared. Now, looking at what happened, besides, of course, having this merge with the CT scan to see that we were kind of free from coronary arteries at the site of ablation, but you see here, there is some atrial activity that is going on in between QRS, so that has to be disregarded. Then we try again, as said before, to chop the diastolic interval into 3 parts. And what we consistently could find, it was only entrance electrograms, nothing in mid-isthmus, nothing in exit. So our reading was, so we had a 3D substrate, entry subepicardial, exit endocardial, and we're kind of fortunate that we were able to achieve success by providing sequential unipolar lesions to get into the depth of this. Now, from the practicality standpoint, again, as said, I want to discuss a little bit how are we coping electrocardiographic information with etiology that, for me at least, remain one of the mainstay to take a decision when should we go epicardial. As said before, for us, as I guess for many of you, ARVC and myocarditis is a kind of go epicardial as first line, and that was kind of shown in this analysis. Out of the 620 and more epicardial procedures that we did in these years, 317 were first line, and they were done, as you see here, in about 15% of the patient myocarditis and ARVC. The odds for the presence of an epicardial substrate, so recording and actually performing ablation, were very high, both, as you can see here, in the ARVC and in the post-myocarditis group. So this is actually very significant. It means that every time you had kind of this disease etiology, very likely you can go and had a good selection of ablation sites. So and so for post-infarct, and to our surprise, the most miserable yield of the, so to say, etiology-driven approach was for IDCM. So that is really non-significant. It means that very many patients that had undergone an epicardial puncture for ablation in the setting of a true IDCM will turn out to have suffered a useless epicardial approach. Why that? I think that Frank has shortly alluded to this reason. There are basically two main subgroups of scar or disease process localization in this patient. One is mostly septal and one is free wall. You were kind enough to quote this paper. It was one of the last contributions of Professor Valens with us, and I think, again, I don't want to waste time to reiterate the notion that sometimes sinus rhythm electrogram allows prediction, and the rule is kind of simple: normal PR, narrow QRS, more likely related to a free wall disease process, basic dependency, wide QRS, bundle branch block, more likely related to a septal disease process. Kind of easy for you to decide upfront if you don't have VT morphology, if you don't have imaging, what should I do today? Again, talking about disease, non-ischemic etiology, two big subgroups. What can you expect from the VT morphology to enlighten your choice? In the upper line, septal disease, you see here, bipolar scar, unipolar scar, late potentials, pacing dependency, type of VT that you expect usually in the septal type, anteroseptal type scarring process where epicardial is not useful at all, kind of leftish bundle, inferior or intermediate axis type VT, whereas in the lateral group, free wall disease group, more likely right bundle, kind of superior axis, just to give it a rough approximation. So in conclusion, I think that 12 lead can provide preliminary clues to decide should I go epicardial, yes, no. But at least in our experience, the first indicator is etiology-driven, and let's say is a go for ARVC and post-myocarditis. There are other indicators, 12-lead findings during sinus rhythm and during VT that might suggest should you go epicardial, yes, no. I think that also complete versus incomplete electrical imaging, that is your ability to show that you can completely cover the diastolic interval under either endo or epicardially, may be a good direction of the choice. And of course, MRI and CT imaging can be additionally useful in select cases in post-infarct and IDCM process taking. Thank you very much for your attention.
Great presentation, and we'll move on to the last presentation for the first session. Peter van Dam on can body surface mapping help to improve the decision? Maybe yes or no?
Maybe yes or no. Sometimes yes, sometimes no. Does this work? Whoop, this to find, yes. Improving the clinical decision, not necessarily BSPM, but how can we do that? To localize VT, PVC, I need my glasses, otherwise I can't see anything. You would like to know beforehand where it's anatomically coming from. We had already several examples of that. I'm a cardiac modeler, so I really like to have this cardiac model available. For that, you do pre-procedural planning, which we have seen you can do with 12-lead ECG. You can also do this during the procedure, which is done with CARTO in combination with 12-lead ECG, but you can also do cardiac modeling. Pre-procedural planning, well, we had already 12-lead ECG, inverse ECG, I will come back to that a little bit, and cardiac imaging analysis like in-heart ADAS are packages that try to tell you this is where the scar is, this is maybe a circuit. And basically you want to reduce the procedure time in accessing where it's coming from. I think, especially for inverse systems, and that's where often body surface maps are used, you could use it even intra-procedural, because then you have at least the whole activation of the whole heart, and not just of the parts you map. And with that, you have a very impractical tool, because body surface maps sometimes help, but they're clinically basically useless. So to get to inverse ECG, what is inverse ECG? Well, basically measuring an ECG is V is R times I, just Ohm's law. So we have potentials, we have a volume conductor, our body, and we have something that generates currents, the heart. In forward sense, with ECG sim, you know what the currents are doing. You have a volume conductor and you know the potentials. Inverse, and this is where inverse comes from, this -1, it's the inverse of the R. And with that, you can try to estimate activation and recovery sequences, potentials, or I like to really estimate this I, the transmembrane potential, and that requires then the model of the heart and the model of the thorax and the ECG electrodes, otherwise you don't know how you view the heart and the recorded ECG. The ECG really originates, where does it come from? And I cannot read ECGs. I need really my activation sequences. So why do I have a Q wave? Why do I not have a Q wave? Well, basically, it's just an electrode is kind of a camera, and it looks at the heart, or basically at the electrical part that's activated. And here you can see that the blue and the red give you the same signal size on V2. Whereas if you look from the side, V6, then you don't see this wavefront at all. I think this is an important concept. At least this is how I always look at an ECG. So the ECG is basically determined by proximity and the relative location of the activation wave. Well, body surface map, here you see an example as we measure them at the moment on especially ARVC and ischemic patients in Utrecht. And we use 67 electrodes. There are systems up to 200 to 255 electrodes, which is really huge. Basically, you cover the whole thorax, back and front. Interestingly, I thought most people don't see that, but basically less than 15% of the body surface map electrodes are less than 10 centimeters away from the heart. So you don't see anything proximal for most of the leads that are on your back or on the side of your thorax. And this needs to be taken into account when interpreting the body surface map. Also in the ECG, but if you have all these electrodes, some ECGs just look very globally at your heart. And this is, I think, an interesting example. This is a normal, we had 7 normal controls, and my student made different time intervals body surface maps, and this is a typical normal body surface map over time. So here a positive, somewhat negative in the onset of the QRS, and then moving here it gets positive, and at the end of the QRS, the upper part of the body surface map of the body gets positive with a negative point here at V5, V6 region. We did this also in ARVC patients, and then she discovered various patterns. And one of the things that's really interesting, I thought, is in some patients you find really on the right side, basically looking at the right cusp, the tricuspid cusp, mid-QRS, a weird pattern compared to normal. But there are different patterns, and you see something similar in repolarization. So I think this is an example where body surface map can really help, because especially with ARVC, you have so many differences in activation and recovery that body surface maps can maybe really help you to identify these patients in a certain stage, because the disease is so heterogeneous. Do we need that to localize a pacing lead or a PVC VT? And that's what I did together with Josef here. So we have, for that, the inverse ECG. You need a volume conductor. So we had CT, we have body surface map, 99 leads. And from that, we try to estimate where is this lead located, left or right. And in general, we could say there's no real difference between left and right with body surface map and 12 leads. Oh, just to go back. No, not. Can I go back? Or no. Here you see the average distance for 12 leads. Localization error was 8.3 millimeters. If a body surface map, it's 9 millimeters. And the similar results for the RV. You may wonder why. Well, you have a volume conductor. We didn't include the lungs, so the volume conductor was not perfect. With the 12-lead ECG, you have more electrodes just over the heart, whereas the body surface map is everywhere, so it had larger errors, and in the end, it didn't produce then the results you would have thought it. But especially the spatial error was relatively close with 9 millimeters, less than a centimeter, localizing these pacing leads. This is an example, 12 leads on the left pacing lead and a right pacing lead, and the other one with the body surface map. And this is then the intrinsic activation we estimated also from 12 lead, and you see very similar patterns. Just note, these patterns are very simple. It's a single activation site. Left bundle is also relatively simple, just activates from the right to the left. As soon as you get to complex sinus rhythm with multiple breakthroughs, you need probably more than 12 leads, but that's the current research. We did something similar in Aalborg with localizing the RV lead again from the 12 lead, patient-specific models, and again, relatively good results, similar, a little bit less good than what we accomplished here, but still clinically useful. Then I've also been working on the Vivo system, which is still available. This uses just a 12-lead ECG and a patient-specific model, and in Rotterdam they try to validate that. And sometimes it works good, and sometimes it just doesn't. And basically similar to what you see, these septal sites, sometimes also in this kind of modeling, they have problems. So I thought this was a very honest study. Never think that everything is the truth. So just for discussion, PVC and VT origins often produce activation from a single location. Sometimes it picks up the His-Purkinje system and then it becomes more complex. And I think for those kind of relatively simple waveforms, you should not be need body surface map. So for that one, I would say don't use that. The structural normal hearts, the PVC-VT can then just always be located with 12 leads. That's my opinion, my experience. Inhomogeneous myocardium, scar, fatty tissue, etc., like with ARGC or scars, needs to be considered with ischemic VT PVC. That might use body surface map or scar mapping. I'll come to that later. And the diagnostic accuracy might be improved using BSPM for these kind of patients. So in conclusion, please use the 12-lead ECG just for PVC. If a human can do that, a computer should be able to do that too. My current research, the last two slides, is that I try to build in SCAR in the model I use, and I hope to be able to get these kind of re-entry or slow activation circuits localized. So the method is already there, but for that I need to know exactly where the scar is. Well, and there are at the moment 2 commercial products available, InHeart and others. So this is an example. So I have my body surface map, my torso model with a heart model, and I've started to incorporate, this is now my single activation line, incorporate the electrical activation in combination with the InHeart model. And here you see, it's not very clear, but for those who want to see, this comes from a papillary muscle. Here you see all kind of scar. The VT never came from there. But this very simple activation line already localized it closely to the papillary muscle. This was the VT. And with others, you can do basically the same. So now you can suddenly start to relate the electrical activation on top of the anatomy. And I think this is where we should go, because now we can use this also intra-procedural and really start to relate, hey, this is SCAR, this is what the electrical activation more or less looks like, and we really use the 12-lead ECG in combination with everything we've got. Well, I don't think I listed them all, but thanks to my collaborators and students, thank you.
I think we can.
Well, thank you, Peter. Great presentation, and thanks to everyone for the great presentations. We have time for a couple of questions. Is there any burning discussion points from the audience? Frank.
Yeah. Not sure which mic will work, but we'll try. No, I want to just emphasize to the audience that, as you pointed out, and you had your top of your slide, the ECG will never lie. We have to be able to use it to accurately interpret. So I think that I would just like to comment that when you have a patient who comes to your laboratory and is on a boatload of antiarrhythmic drug, then those drugs will influence things like the interval criteria to determine whether something's endo or an epi, and you should recognize that and maybe dismiss it. You also need to know when you have a big infarct, you can't use a Q wave to diagnose the presence of an epicardial origin, because the infarct is giving you that Q wave already with the ventricular arrhythmia. So it doesn't suggest that it's epi, it may be endo origin. We know that most VTs in ischemic cardiomyopathy originate from the endocardium. So we have to be clever about using criteria and saying, I like it when it doesn't work, to be honest with you. When it doesn't work, I spend a day or two saying, why didn't it work? What do I need to know to understand? So, for example, Paolo's case where he had an inferior scar and that looked like it was exiting towards the septum. One is positive, so it's septal origin. And the QS complex in the inferior leads, said it might be epicardial because of that in terms of the activation. So it's sort of fun to sort of take the ECG after the fact and figure out how can I get it to apply? What did I miss? And does it apply? And as Paolo nicely demonstrated, some of this is, it's not an endo or an epi circuit. And that's been demonstrated by others. And that it's a circuit that involves the endo and epi. And perhaps when you miss, and that's an interesting criteria, obviously, but when you miss the mid portion and you have entrance and exit on the opposite side, you may be able to go back and either it's intramural or it's epicardial. And same thing, you know, in where's the exit portion of that circuit? And the exit portion of the circuit will dictate the ECG. It doesn't say where you should ablate. The ablation is in the best served in the middle isthmus. It sometimes works towards the exit, sometimes works towards the entrance, and that's why we've been successful with the ischemic VT, but you need to still recognize there's a limit for the ECG.
Part of the problem is also that you have inadequate tools still to get to this, let's say, mid-myocardial substrate. So you can identify correctly, but and it does not help because you cannot penetrate with your radio frequency or cryo. So I believe based on experience now with pulse field in atrium and based on some early experience in ventricle with these large footprint electrodes. So this may help to really get to the target where you identify with mapping or with ECG. So I believe it will change success rate, hopefully, in the next couple of years.
Maybe I can make a comment on that as well. So that is true for the reentrant VT. For the focal arrhythmias, I think the ECG may be a very good tool to localize. But for the reentrant VT, as you said, we just get directed towards the exit. And it would be nice to have a high-resolution ECG that would identify those diastolic activation, but that's just too minute to really show it on the EKG, I think.
Yeah, and diastolic, if it's a big circuit, obviously you may be 4-5 centimeters away for where you really need to ablate.
Exactly.
And it's just important to recognize all that.
If I may, sorry, a fantastic session. And Frank, I have the deepest admiration for your knowledge and skill with ECGs. It's always amazing. And I have a question because I think Thomas did a very nice job also at describing the impact of the position of the heart in the thorax. So is that something you pay attention at systematically and try to understand the degree of rotation, for example?
No, I think it's one of the most important things. So, and it's age dependent, and you know even how the aorta sits is age dependent. The aorta gets uncoiled, the aortic root therefore gets shifted from being horizontal to more vertical. All these things are ultimately going to influence the ECG pattern. So, you know, when we looked at the criteria for the precordial leads, I mean, for years we would just do it intuitively and say, you can't look at a PVC without knowing what the sinus rhythm QRS transition was. And then Dr. Gerstenfeld and one of my younger colleagues got very fancy with this transition ratio and added a number to it. But it was really the basics was you need to look at, but you can use the patient as their own control. So for example, you can use the patient as their own control for endo versus epi. Because if you go endo and you pace directly opposite to where you, or directly where you think it should be, and it looks completely different and much more narrow, you already have a clue, another clue that you can go epi. So again, using the patient's anatomy, understanding it, and how it influences is really critical. And I think that's part of imaging too. You know, how the value of imaging. Because if you know the rotation of the heart and the chest, it's very nice.
And Peter, do you think, so I noticed the errors in the localization that you still have that is around I think 1 centimeter.
Oh.
Is it something that is intrinsic to the inverse problem, or do you think that it can be improved?
You will never get to. I think you never get to carto accuracy. You have to be there because you measure the exit site at best. So you always have to ablate probably a centimeter away. So the centimeter just brings you in the region and not close. By the way, about heart position, you can predict basically the heart position and orientation somewhat just on chest circumference, not age. The age does something, but the most important is really chest circumference. There are people who have more round, and then I have more space. My heart is already lying since I'm 40. And then I had a student who was really very, and I want to measure him again, but that heart is still vertical. So that's something you automatically already do, but I was surprised it's not necessarily age. There is some age component, but the chest circumference is, and the other thing I never hear is the His-Purkinje system, because this transition depends really on on where is the His-Purkinje system. And what I see with my senior ECG is that it's often one pattern, but there are hearts that are more or less activated base apex. My assumption is, I don't have the data, is that it starts close to the base. The papillary muscles are, for whatever reason, in these patients high, and then you have probably a shift in transit. I've never related that. I don't have the data, but that must be somewhere there, just to papillary muscles, I think.
Well, I think, thank you very much for this very, very interesting and exciting first session to kick off the third TogetherVT, and I'm really looking forward to the next sessions. Thanks to the speakers, thanks to you, and coming up is more. Thank you very much.
Good. Okay, now Pierre and myself will be acting as chairs for this session on imaging. Imaging is an important element on VT ablation. The first speaker of this session will be Daniele Muser from Udine. How much should we evaluate patients with clinically idiopathic PVCs/VT? Daniele.
Thank you so much for the invitation. It's a great honor to be here today. So, what I would like to do with this presentation is, first of all, to define idiopathic ventricular arrhythmias, and then to show why and how should we evaluate these patients. As we all know, the definition of idiopathic ventricular arrhythmias is the presence of arrhythmias arising in the absence of an underlying structural heart disease. To rule out structural heart disease in these patients is of extreme importance, because we know that patients with a completely normal heart have a very favorable long-term follow-up, while patients with an underlying structural heart disease are at high risk of sudden cardiac death. How can we evaluate these patients? We have some routine diagnostic tools, including 12-lead EKG, Holter monitoring, exercise stress test, and of course, echocardiography. And then we have some advanced imaging techniques, including cardiac CMR, CT scan, and even FDG PET. The truly idiopathic ventricular arrhythmias have some specific features. First of all, they typically originate from some specific sites within the heart, and for this reason, they have a specific QRS morphology. In about 70% of the cases, idiopathic ventricular arrhythmias arise from the RV or LV outflow tracts. They usually present with monomorphic isolated PVCs, which are suppressed by exercise. So the presence of ventricular arrhythmias with an atypical QRS morphology, or ventricular arrhythmias which are complex, polymorphic, multifocal, or which are exacerbated by exercise, should always raise the suspicion of an underlying structural heart disease, leading to further examination. We know that sometimes routine diagnostic investigation can miss subtle myocardial abnormalities that can be detected by advanced imaging techniques such as CMR. CMR has demonstrated to be able to identify scar even in patients presenting with normal EKG and normal echocardiography. In about 1/3 of the cases of patients presented with any kind of ventricular arrhythmias, and in about 10 to 15% of the cases presenting just with PVCs. But we also know, which is even more important, that the presence of scar detected by CMR is associated with an increased risk of major arrhythmic events during follow-up. This is the case of a 30-year-old female presented with palpitations related to frequent PVCs with a morphology consistent with an origin from the inferior papillary muscle. She had a normal EKG, as you can see, and she had an unremarkable echocardiography, but for the presence of a mild mitral valve prolapse. We perform, as we always do in these patients, an exercise stress test, and what we saw was that she started having more and more PVCs, couplets, triplets, and eventually runs of non-sustained monomorphic VT at 200 beats per minute. So we decided to perform an MRI, which confirmed a normal LV in terms of dimensions, ejection fraction, thickness, confirmed the presence of a mild mitral valve prolapse, but also detected a mitral annular disjunction at the inferior lateral wall. The MRI helped us to further characterize the arrhythmic substrate of the patients because, as we can see, the continuous mechanical stress induced by the abnormal motion of the mitral annulus, in this case, led to local inflammation, which can be detected by FDG PET, and eventually fibrosis that sustains the reentrant arrhythmias. The question here is, should we always perform an MRI in every patient presenting with apparently idiopathic ventricular arrhythmias? The answer is probably no, because MRI has some important limitations. First of all, it's time-consuming. It takes about 40 to 50 minutes to perform just a routine examination. It's expensive, not widely available, and we have always to remember that it can be deeply affected by artifacts related to the presence of ventricular arrhythmias. If we look at the studies that had investigated the diagnostic role of CMR in patients presenting with apparently idiopathic ventricular arrhythmias, we can see that all of them have identified a subgroup of variables associated with the presence of scar. Those variables include some strong predictors that are all characteristics of the ventricular arrhythmias, such as exercise-induced ventricular arrhythmias, arrhythmias with the right bundle branch block morphology, especially if with the superior axis, and multifocal arrhythmias. Then we have some weaker clinical predictors, including family history of cardiomyopathy or sudden cardiac death, male gender, and age. We investigated the predictors of myocardial abnormalities on MRI among patients presenting with non-sustained apparently idiopathic ventricular arrhythmias, and we confirmed that those 5 elements were independent predictors of scar. So we have developed, using them, a multiparametric risk score, which we called alarm score, that can be used to stratify these patients. Once we stratified our population, according to the tertiles of the score, we can see that the probability to find scar goes from 3% in the lower tertile group up to almost 50% in the higher tertile group. So this is an easy tool that can be used to identify those patients who really deserve a CMR. But is the presence of scar the only determinant of risk in these patients? The answer to this question is not that easy, and I want to show you some data that can help us to reflect. This is a study that have compared patients with normal LV dimension, normal LV function, and without evidence of LG, to patients with normal LV function and dimensions and presence of non-ischemic LG. The authors found that those two groups of patients had an absolutely superimposable long-term mortality. This is another study that have compared, again, patients presenting with normal LV function and dimensions, no LG, to those with a minor non-ischemic pattern, characterized, for example, by the presence of LG in the RV insertion points or mid-myocardial LG at the basal inferior lateral LV wall, to those with a major non-ischemic pattern characterized by a subepicardial LG or LG involving the interventricular septum. And what the authors found is that only patients with a major non-ischemic pattern had a worse long-term outcome, while patients with a minor non-ischemic pattern had a similar outcome to patients without LG. But we have to remember that both of these studies did not include patients with ventricular arrhythmias. So if we move to the group of patients with ventricular arrhythmias, we have investigated the presence of scar among patients presenting with typical outflow tract PVCs, so patients that by definition should have a normal heart. And even in this group of patients, in very few of them, we have found the presence of scar not related with the site of origin of ventricular arrhythmias. Again, the scar had the non-ischemic pattern, a so-called minor non-ischemic pattern, like the presence of mid-myocardial scar at the LV basal inferior lateral wall. And after a median follow-up of 5 years, none of these patients experienced major arrhythmic events. But if we look at the same patient population, patients with typical outflow tract ventricular arrhythmias, and in this case we look at those with a scar consistent with the site of origin of the arrhythmia, we can see that the outcome is completely different because 1/3 of the patients experience major arrhythmic events. So, for this reason, a risk stratification strategy based only on the presence of scar is probably not enough, but we have to look for some characteristics of the scar that can help us to identify those high-risk arrhythmogenic scars. Those characteristics include the relationship between the scar and the site of origin of ventricular arrhythmias, the total amount of scar, so the scar burden, the distribution of the scar, so the scar pattern, and then we may have some intrinsic features of the scar that makes the scar arrhythmogenic. We know that the total amount of scar is a strong predictor of sudden death, even in patients presenting with PVCs and normal ejection fraction undergoing catheter ablation. We also know that there are some patterns of scar, for example, the coexistence of scar involving the interventricular septum and the LV free wall, that have been associated with a high risk of sudden death, regardless the underlying ejection fraction, in both patients with previous myocarditis and non-ischemic cardiomyopathy. We also know that there are some very specific scar patterns, like the ring-like scar pattern, characterized by a circumferential layer of scar involving DLV, that have been repeatedly associated with some genetically determined high-risk forms of left-dominant or even left-isolated cardiomyopathies. We have found this pattern even in patients presenting with non-sustained apparently idiopathic ventricular arrhythmias, and we have confirmed that is associated with an increased risk of sudden death compared to patients with presence of scar but with a different pattern. And again, this is probably related to the underlying cause of the scar, which in a lot of cases is a genetically determined disorder. When we performed genetic testing in these patients, we found pathogenic mutations of genes like filamin C, lamin A, plakophilin, desmoplakin in about 40% of the cases. Finally, what makes the scar able to sustain reentrant circuits is the heterogeneity of the scar determined by the presence of areas of dense fibrosis coexisting with the areas of viable myocardium. And now we have some radiomic texture analysis techniques that are able to quantify this heterogeneity and that have been correlated with worse long-term clinical outcomes. To conclude, the presence of an underlying structural heart disease is the major determinant of risk in patients presenting with apparently idiopathic ventricular arrhythmias. Usually, routine diagnostic investigations are more than enough to rule out structural heart disease, but sometimes they can miss subtle myocardial abnormalities. And we can remember that there is a group of clinical variables and some characteristics of the ventricular arrhythmias that can help us to identify those patients who really deserve further investigations with CMR. Finally, let's remember that there are some specific scar patterns that may be the expression of an underlying high-risk genetic cardiomyopathy, which deserves careful evaluation for ICD implantation, family screening, and genetic testing. Thank you.
Thank you. Thank you very much, Daniele. Very, very interesting presentation. I learned a lot. And so we now have our host, Josef Kautzner. Josef, again, this is wonderfully organized. Thank you so much for having the TogetherVT meeting in Prague. And you're going to present on eyes. And it's, I think, performance in structural heart disease VT and how to use it. Thank you, Josef.
Thank you for introduction. And as you heard, I will talk about the use of eyes, which is still neglected when we talk about VT ablation in many meetings. And I would like to start with a clinical vignette that we had a patient who had a dysfunction, posterior wall hypokinesis, probably myocarditis because he had normal coronaries and he suffered from type 2 myocardial infarction during sustained monomorphic VT, was implanted with ICD in the other center. He was sent to us for ablation. And you see two morphologies, one of them more from basal part, one of them in the middle portion of the ventricle with different axes. And when you look at this intracardiac echo, you see immediately the thinning of the wall in posterolateral region and probably epicardial location, but also endocardial. And we did initially mapping endocardial. You see the voltage is normal. Almost normal in that area close to the valve. You see these late potential areas. We started ablation in that area, but then we noticed that we have a problem. We have hemopericardium. But when you see this, we always take out our tamponade box. We do drainage. Before the patient develops, obviously, any hemodynamic compromise, then we reverted heparin, and we continued epicardial mapping, and you see a large scar and also late potentials in that area, and we did complete modification of the substrate and reached non-inducibility. So would this be possible if you don't have intracardiac echo online monitoring, to do such a nice case? Even though you have a complication during endocardial mapping. So let's talk about point by point, what is the main role. Obviously, it's online cardiac anatomy, especially if you do these idiopathic arrhythmias in outflow tract, but often in non-ischemic, as we heard, you have part of the substrate which is really very close to the valve and could be even ablated sometimes from the cusp of aorta. So you see really very nicely, both in longitudinal and transversal view, which cusp you are dealing with. You can map millimeter by millimeter within each of them, and you don't need to do coronary angiography, obviously, because you see everything on eyes. And here you see again, this is example of right-left commissure ablation. This is also not only in an idiopathic setting, but sometimes you have a critical part of the substrate even in structural heart disease patient with non-ischemic cardiomyopathy. You can see also extensions into pulmonary artery, like here, you see. So sometimes there is also focus for idiopathic there, but you can also find something in structural, especially in patients, for instance, with congenital heart disease and after correction, like tetralogy of Fallot. Right ventricular cardiomyopathy, you see a lot of trabeculations. You can see the size of the ventricle, and you can see thinning of the wall. The same, you can go for structures inside the ventricle, like moderator band, This was idiopathic patient, but you know that sometimes it is a triggering focus for ventricular fibrillation. It might be also in the setting of cardiomyopathy. Obviously, guidance of transeptal puncture is amazing. You can do so safe puncture. In thousands of punctures, we never had a problem. If you follow the rules, it can help also in some difficult anatomies. You can do easily 2 transeptals, and there is no problem. You can, if it's a really very resistant septum, you can use safe set wire or other tools, and you can follow again where it goes. But if you don't follow the rules, like one of our former fellows, and you do puncture very posterior, as you can see here, when we came to the lab and we saw this, we were prepared for this. So we did the whole procedure. This was a AFib case. At the end of procedure, we took out our tamponade box and we prepared everything, and then we pulled back the sheath. And you see accumulation of blood. We did the drainage, reverted heparin, and everything went fine. But you would not do this if you don't have this imaging. Location of ablation catheter and contact. This is reality. These are patients with non-ischemic cardiomyopathy. You see sometimes clearly where is the substrate. You see a lot of structures inside. If you don't visit this area, you miss. If you have some multipolar catheter, you may miss these areas. So this is virtual reality, and this is reality. So I don't need to comment more, I think. For bipolar ablation, it can help you again to localize against the septum from both sides much better than X-ray. Obviously, we are a big transplant center, so we see every year several patients with LVAD, and mapping with eyes on LVAD is very important, because if you get close to the cannula, close to the device, you have disturbance of magnetic field, and you cannot use appropriately you cannot use appropriately CARTO or other mapping tool because of this distortion, but you can still see where you are on ice. Obviously, it can help also to localize your impeller device if you want to map during tachycardia for some reason, and it can help again to this is a patient with this parietal band VT, where you can go really underneath the tricuspid valve in lateral position. You can also assess to great extent the substrate. You see here is a thinning of the septum, a non-ischemic cardiomyopathy. Here you see clearly again the change of thickness, you see the extent of the scar, and it helps us very much during the case. If you see a picture like this, there is no point to go endocardially, you go just epicardially, because everything is visible there, and it doesn't cost that much. You know, you don't need to do upfront any imaging. This is an example of mid-myocardial scar. You see the voltage is normal. This is bipolar voltage. I know that Frank would recommend to use unipolar, but if you see the scar here, it's clear that you have to try to get close from both sides, probably. Sometimes you may not see any signals in the aneurysm, even though it was not visible in procedural echocardiography, because there is a calcification, and sometimes it can, you don't, if it's old thrombus, you don't see it on a normal echo. But here you see clearly where it is, and we have some paper that you can do safe ablation if you have old thrombus, but you have to do usually circumferential ablation, because otherwise you cannot get through the thrombus to this area. This is another example of a big thrombus in posterolateral region, and we had to ablate actually epicardially around this area. So this can be all visible on intracardiac echo. We also developed sort of strategies how to monitor RF delivery. If you see, this is a patient with idiopathic VT, where you see this whitening of the tissue. It means that you are heating the tissue close to 100 degrees because you are creating microbubbles which are visible. And this is an imminent pop, I would say, if you see this. So you either downregulate the power or you will see this one. So it's a blast in the tissue. And it can penetrate, especially in normal tissue, if there is no dense scar and you have such a pop, you can penetrate through even thick myocardium. I saw a case more than 1 centimeter thickness, and it went through because it goes, expansion of gas makes a zigzag tear through the myocardium. So this is just to show you how it looks like if you see experimental pop in pig, and this is a result. It's a tear of the tissue. So to hear pop is not just an acoustic phenomenon. And this is sudden whitening, and even in sudden whitening, you have some hemorrhages and you have some damage. You may have some damage to the tissue. So that's why we look at the application areas. And we look for this whitening, and we try to regulate the power depending on that. Early detection of complications. I showed you already that if you see separation, you can be prepared on some problem. This is a wire in the right ventricle during attempt for epicardial mapping. So if you see wire in the right ventricle, you know that you are in the wrong chamber, and you pull out and you change the position. I would like to remind you that our strategies to anticoagulate heavily patients, especially for AFib ablation, but also for VT ablation, if they have smoke-like echoes, came from Frank's place in Philadelphia. This was a first study showing that even if you keep ACT 250, which was believed many years ago as a standard for any intracardiac procedure, you can find thrombus on catheters in about 10% of cases. So since then, we started to heavily anticoagulate the patient. That was intracardiac echo that helped to develop these strategies of very, I would say, heavy anticoagulation. And I always show this case. This was a patient who came to the lab without any thrombus in the appendage. And she was on a low molecular weight heparin. And we introduced the catheter into coronary sinus, nothing more. And before we started to go for transeptal puncture, she started to develop this thrombus in the appendage. So for those people who believe that if you give heparin after transeptal puncture, it's too late. In some patients, especially if they have really these dense smoke-like echoes, you may have already thrombus in situ if you give it after transeptal puncture. And this is a nice case from Fermin Garcia. If you have hypertension, you have obviously, I don't know why it doesn't work. You will always look easily if you have effusion or not, or if you have hypokinesis, or if everything is normal and you have just vagal reaction. But you may have also air embolism, and I don't have such a nice case of air embolism, so that's why I've borrowed one from Fermin. But you can see air accommodated in that area where you... sorry. You see? And you have these elevations. And I can tell you that we have observations that you can have bubbles which are swirling in the aortic cusp for 2 hours during the procedure. If the patient is supine, it's all the time there. So it may go to right coronary artery even 1 hour after you somehow delivered a bubble into the bloodstream. So it is, the temporal relationship may be really completely different what you believe. And sometimes they are even in ascending aorta, just in one spot, like, swirling. And if the patient does not move, you can have them for 1 or 2 hours in the same position. And obviously you can check function. If you see something like this is obviously very high risk for thrombogenesis. If you see ventricle which does not move, you also don't want to do repeated testing unless you have mechanical support. The evidence to use ICE is obviously comes only from observational studies or comes only from experience, because it's very difficult to do a randomized study. If you know, you know, and if you don't know, you don't believe. And it's very difficult to do the same person does the study, which will be randomized and completely like blinded. They cannot be blinded. And there are some data from US databases showing that you can have some, let's say, advantage in better efficacy, less readmissions. There are some, this is from similar database showing especially the redo procedures and reablations, readmissions are less for those patients who had intracardiac echo on board during the procedure. So I believe truly that echocardiographic online imaging is a useful tool to maximize the efficacy and safety, especially safety for VT ablation, not only for VT ablation, but also for other complex ablations. And the evidence is only indirect since no randomized trials have been performed and probably will not be. So thank you very much for your attention.
Okay. So, well, thanks. Thank you very much for your insightful presentation. And it will be my pleasure now to introduce Pierre Jais. Are you really going to talk about the role of CT in structural heart disease?
Thank you very much, Paolo. And again, thank you, Josef. I have to apologize. I should have noticed that in the program we made a double mistake. I'm presenting on CT and then Katja is presenting on MRI, and should have been Katja first because she's a lady. And more importantly, because MRI has been used to investigate the heart for 20 years. And CT is very recent, so from historical perspective as well. I'm going to present on this effort that we've been doing using CT for describing the heart of our patients. It's about 10 years effort, and we have now a worldwide network. It has become clear lately that imaging the heart before considering a VT ablation was probably helpful in describing the anatomy, describing the scar, which quite often matches with the area of interest when it comes to VT ablation, and probably reduces VT recurrences, as pointed out on these guidelines. And so Katja is going to present in depth on MRI, and I can report that in our experience it's super useful to have MRI when it's possible. But as pointed out by Daniele, MRI is not that easy to get access to. An MRI for the knee takes 10 minutes. For the heart, it's an hour or an hour and a half. It's not the same. In private practice, it's not very popular for obvious reasons. So if you look at our experience here, you can tell that patients that are investigated conventionally, I'd say, without advanced imaging, in more than 50% of them, these are VT or VF patients, there is no substrate identified. But then if you perform an MRI, this drops by 20%. So you really identify much more substrate, and you can label and identify properly your patient. And we were just discussing with Estelle Gansbach about sarcoidosis, where this is really absolutely true and super helpful. Now, there are limitations with the conventional approach to VT ablation, where you may have multiple VT that are inducible or observed during the course of the ablation. And you can anticipate that this is going to be a long day, because 9 different morphologies means a big substrate, that is for sure. And I think this is also why the substrate approach became more popular. It's definitely easier to work in sinus rhythm as compared to VT. The level of stress for the physician and for the patient is completely different. And there are other limitations that you know very well. For example, the fact that it's sometimes very poorly tolerated. And even if it's well tolerated at the beginning, as the burden of VT increases as time goes by, it may not be that well tolerated. And it's difficult to imagine that you're going to map all of these VTs if you have plenty of them. So I like this slide because it shows you in the same patient with a previous inferior myocardial infarction, the different aspects of advanced imaging you can get. So on the far right is the MRI, where you have the dense scar in dark blue and light blue is the gray zone. So it's a bit of a surprise, but CT can also give you similar information with late iodine. Now, this is not easy to get. You have to have a late generation type of CT, and you have to have a very good bolus of iodine that is properly timed to be able to get that. The signal-to-noise ratio is not as good with CT as compared to MR when it comes to late contrast enhancement. But it's doable, and I trust that the latest the photon-counting CT scanner will even do a better job here. You can also very well identify the fat, and you benefit from the high spatial resolution of a CT scan. A CT scan typically gives you voxels that are isotrope with 600 microns. An MRI is more 1.5 millimeters, and it's not isotrope typically. So you have this very nice distribution of the scar, of the fat, sorry, in the myocardial infarction. Based on the literature, it varies from 50% to almost 100% of myocardial infarctions that have this fatty infiltration. It probably is not trivial when it comes to the arrhythmogenicity of the scar. And this might become an interesting information for our ablation strategy. And then finally, with CT scan, you can have a very accurate measurement of the wall thickness. And obviously, if you have a wall thickness after the infarction in the scar that is a millimeter or less, there is very few surviving fibers in that area. And even if there are some, well, this is where you find the latest late potentials or lava. But typically during VT, which is a faster rate, it is very poorly coupled to the rest of the myocardium. So most often it will act as a block. And in between the block area that is dark red, you have an area where it's more preserved thickness, where you will likely have an isthmus. And maybe, Katja, you're going to present that work you did a few years ago. I love it. It's one of my most insightful contribution with MRI. So what they did here is that they translated the Carto substrate mapping data onto the slices of the MRI. If you register both things, you can do that. And they color-coded those dots based on the voltage. So red is, of course, less than 0.5 millimeters, 0.5 millivolts, and blue is a higher voltage that is considered almost normal, definitely between 0.5 and 1.5 millivolts. And it's very interesting, and the conclusion they draw from that study is that if you have a rim of tissue that is 2 millimeters thick between your recording electrode in your scar, you're going to miss that, at least with bipolar voltage analysis. Unipolar would be different. So I think it tells a lot, and it illustrates nicely the complementarity of the electrical information with the imaging that gives you that aspect of what is happening in the wall thickness. Which I think is really interesting. So imaging is progressing fast, and the post-processing of images as well, and you can reconstruct in 3D the heart of your patient before going to the lab. And we image each and every patient before a VT ablation in Bordeaux. You have access to the real anatomy, and here you describe the scar. This is showing you the wall thickness as shown before. You can move your slice and see how it shows on the original images. And of course, you have access to the entire anatomy and to the substrate. And you can pre-plan your ablation strategy. You can identify your targets, identify the areas of block, and decide where you're going to plan to ablate. So it's an interesting approach. This is even something you can discuss with the patient. So this is a short video showing you the areas of block. We've identified the isthmuses and the plan that we want to deliver. It's a very large inferior myocardial infarction in this patient, and it came with very unstable rhythmic condition. This is showing you, Fred did that case, I think, Fred Sacher. We are fast mapping the pulmonary artery to register the reconstructed heart of the patient with the pulmonary artery anatomy we take from the fast mapping. And you see a patient is in VT. We identified it was the most apical isthmus that was the most active. So we straight took the ablation catheter to this area and started working in this distal part of the scar. And it was really not easy because the blood pressure was going down. You can see here that it's really low blood pressure, but it was successful in taking care of this isthmus so quickly that we had the liberty to work without any hemodynamic support. And then the rest of the scar will ultimately be considered. So it's an approach that allows to deal with some complex cases and unstable patients pretty nicely. It's been quite validated with over 50 publications. And one of the, it came to us as a surprise, a complete surprise, that the wall thickness analysis would match that well with VT isthmuses when these isthmuses are mapped. And this is showing you one of these matches where this is the relatively preserved thickness in the scar that matches so nicely with this VT isthmus. We in fact identify more CT isthmuses than VT isthmuses. And I think this makes sense because we know that not all patients are inducible, even though they have a clinical VT. So it's to be expected that you have more imaging targets than inducible VT show you. In our experience, it's interesting because it shortens the procedure duration quite dramatically. It's a mean of 2 hours, and the standard deviation is very limited. It's I think 20 minutes. So it's very, very efficient in a way, and in our experience, it's also associated with fewer recurrences. There's more to it. You have a platform, which is this model of your patient heart that you can use, and Natalia will show more of this. But we developed this model where the wall thickness is translated into conduction velocity, and by doing so, you can then test your model to identify whether some VT is inducible in silico and see where it would propagate. And so this is what we observed mapping this patient. And this is the in silico version of it, which shows you the same type of circuit, but it's purely in the computer. This, in fact, takes advantage of some of the steps that we're doing anyway, which is the mostly automated segmentation and LV wall thickness computation. And then again, you have this model where you derive from the wall thickness the conduction velocity, action potential, duration, and you have some fiber orientation knowledge on top of that. And then you can run in the computer, based on the exact anatomy of your patient and the scar of your patient, you can run that program stimulation purely in silico, and it's pretty fast, and you can identify. So for example, you could test 100 sites, and this is what we're doing. 100 sites is of course not clinically feasible, and you can have statistics. So for example, this patient has been induced from 20 sites out of the 100. It's probably more meaningful than a patient that has only one site that induces VT, or no sites inducing VT. So you start to think that maybe this could be used for risk stratification as well. So this is another case where you see the drive, and you're going to see the circuit that starts here. That's in silico, and this is in vivo. Pretty good match. Same thing here, in silico, in vivo, and again, this is the drive, and then the VT is going to start. The next revolution is almost there. I mean, photon counting CT scan is an amazing modality. It has been installed in Bordeaux just 2 weeks ago. We're not yet up and running, but hopefully soon. Some very frustrating, paperwork that is taking time. But it's exciting because this is showing you. It's at scale, the voxels by a conventional CT scan as compared to an MRI, and you see that the spatial resolution is really very much better with CT scan, but photon counting is amazing. That's 100 microns voxels. So it's going to be absolutely incredible, and so my son made that voxels. This one is the MRI, this one is the conventional CT scan, and this thing you barely see here is the photon counting CT scanner. It's a revolution that is super interesting because it's going to be associated also with a much better tissue composition analysis. So you can you can quantify the energy of the photons that are emitted, and it varies based on the tissue composition, so that spectral analysis of the signal, plus you have access to plenty of contrast agents. So really something very, very exciting that is about to happen. Thank you so much for your attention. And so, as mentioned before, it's my pleasure to invite Katja to the podium. So she has a huge experience with MR describing the scar of the patients we are ablating and considering for ablation. Thank you so much, Katja.
Thank you very much, Pierre, Paolo. So actually, I'm probably more talking about the present and not about the future a little bit, because there are several roles for CMR in structural heart disease right now already. And one important tool is, of course, CMR as a diagnostic tool. And of course, in post-infarct patients, we usually know the substrate from the history, from echo or from CAS studies. But for patients with a DCM or a hypertrophic phenotype, both classical LGE sequences, but also more advanced sequences can say something about the underlying etiology and also about phenocopies when it comes to inherited cardiomyopathies. And this is from a very nice recent imaging study showing actually the association between the imaging phenotype and the genotype in patients with inherited DCMs. You can see that this ring-like pattern, and the definition is sometimes kind of confusing, but in this study it was like in particular subepicardial LGE in at least 3 contiguous segments in the same slice. And this was more often observed in desmoplakin filamin C variants, whereas in all the other variants it was more the mid-wall pattern in particular affecting the septum. And this is not only a kind of academic exercise, because first of all, if you have a genetic mutation, then the combined outcome is poor in patients. But in particular, if you have mutations in the nuclear envelope group, and most of you, of course, know the LMNA mutation, then both the combined endpoint, but also end-stage heart failure is much more likely. And this is very important to consider also in our ablation patient population. Because if it comes to patient that we bring to the lab for VT ablation, we have performed systematic genetic analysis in all of these patients, then having a pathogenic mutation is associated with a very poor probability of VT-free survival. This is only after 2 years. And this is not only true for the LMNA patient, but also for other pathogenic variants. And of course, this is not a genetic talk, but genetics are very important in the context of MRI in patients with non-ischemic cardiopathy. And these are just 8 examples, actually on the left 4 septal, on the right more subepical lateral scars of patients referred to our lab. And all these 4 here on the right were all referred as a post-myocarditis VT. And this brings me to the importance of genetic testing, because these 2 had clear and inherited myopathies, so phospholamban and filamin C mutation, which is important for the counseling of the patient and the family, but also for the overall prognosis and also probably how aggressive we are with heart failure evaluation in these patients. Having said that, bringing the patient to the lab, these MRIs have very important procedural implications, because we determine in our lab the excess upfront based on the MRI, not on ECG criteria, but really on the MRI. And you can see that in these patients, for instance, you would end up with an endocardial LV-RV approach only. This patient perhaps only needs an epicardial approach, and this certainly needs both endo or epicardial, in my opinion, looking at the intramural LGE distribution. But you can also get upfront information about inaccessible regions, like in this example here, there's a left main, but also in a hypertrophic cardiopathy. So if you have any single region from this area, impossible to reach with RF application from any of these regions. And the impact of pre-procedural MRI, in particular in non-ischemic cardiopathies, has been shown by Frank Bogun many years ago already, when he implemented an MRI protocol in 2012. And you can see the success rate. This is complete success after having implemented the protocol was much higher if you have the MRI information available. And I think one important information actually from the MRI are the mid-wall scars. And this is, again, a patient with an LMNA mutation where we have really difficulty to clearly delineate this kind of LGE, what we believe is associated with the VT by voltage mapping, at least if you use the standard cutoff values. And this is just the patient with 1.5 millivolt here at the septum. You don't see any abnormal low voltage electrograms. It was the same on the RV side. This is a segmented scar for comparison. So most of us believe that unipolar voltage has a larger field of view, and I'm more than happy to discuss this. And indeed, if you look at the unipolar voltage map here, you may see this intramole scar, but if you end up with other cutoff values, so all of a sudden the scar increases. And this is also quite important information because our cutoffs for unipolar voltage are first based on the great work of Frank, based on normal subjects, and then we use 8.27 millivolt to delineate scar. But if you look at the comparison between voltage mapping and MRI data, there are all of a sudden huge variations of cutoff values to delineate scar. And this is also based on the method how the MRI images are processed, and I will come back to that a little bit later. The practical use still in these patients with mid-septal scar, in particular at the base, is shown in this a very fast case, a 71-year-old male who was referred to our center for epicardial VT ablation after 2 failed ablation for idiopathic VT. Imaging studies were reported to be normal, and this is just kind of refresher from the first session today. This is his ECG, a cycle length 327 milliseconds with dominant S in V1 in early transition. So this is following Thomas' algorithm. This is the LVOT region. We also like to look at the QREF ratio in AVL, AVR, giving a more right or leftward shift of the exit side. So in this patient, it was 1.22. So we think that this VT was originating somewhere from the right coronary cusp region. And we thought probably this patient does not need an epicardial approach. But when we brought him to the lab, we could induce several VTs, including this very fast VTs, which were well tolerated, but also slower VTs that continuous changes the exit side. So this is something that is quite difficult to map, in particular if it changes all of a sudden to a completely different morphology. So very brief looking at the voltage mapping data, and I just give you a couple of voltage maps and the cutoff values. So this is 1.5 classical, and this is for the RV, the bipolar voltage classical 1.5 millivolt. By the way, all the yellow text are pace mapping sites, which we usually also perform extensively in this patient. And now it's about unipolar voltage. This is for the LV side with, again, the different cutoff values. And perhaps you may say there's something here in the periaortic region, but very often this is very often in a low voltage unipolar voltage area because we have all this fibrotic structure around in the perimembranous septum. So it's probably not really reliable to identify a scar. And if it then comes to the right ventricle, it's much more difficult because there are variable wall thickenings in the right ventricle. There's a septum, there are the different structures. And again, Frank's group has early appreciated that you may need different cutoff values for different regions. We have done the same in our lab, but all of the message is here, whatever you apply, you get a huge variations, and no one knows what is really the truth. So for these patients, MRI is very helpful, and this is actually the MRI we have performed in our lab in a second step, and you see nicely this subaortic scar here, which was not visible or reliable visible based on our voltage mapping. And what we did is we have segmented the scar and have integrated it with a CT scan. And this is also very helpful, and this was mentioned already for the planned access, because if you see the segmented scar here, and if you see the CT scan, this is, I apologize for the same color here, this would be the area which we may consider for an epicardial approach. There's a left main, there is a huge layer of fat, so impossible to approach from the epicardium. So these patients should certainly not enter the lab with an epicardial approach. So what we have done in this case, we have simply targeted the projected scar, which is segmented here. These are the ablation lesions, and after that, we could induce one remaining VT, which was a slow VT one, and this had really diastolic activity in the right coronary cusp, and we could terminate by ablation. He was non-inducible. So for the non-ischemic, in particular mid-wall LGE areas, I think image integration and MRI is very helpful. So what about the role of CMR for post-MI scar location? I really start with scar location because we have already heard it's expensive, it takes some time, and do we really need it? And we have kind of refined voltage mapping. We have done this in post-infarct scars. This was actually done by Marek Stramko from the center here when he was visiting Leiden. And Pierre has already shown our technique of reversed registration. And we have done this in a larger group of post-infarct patients. And we have separated the patients in those with a good function of the LV apart from the myocardial scar after infarction, and those with a remodeled LV, because we think, if you think about that voltages just reflects via myocardium, then you should have in adverse remodeled LV lower bipolar voltage, so different cutoff values to delineate the compact part of the scar. So we have done separately projected all the mapping points on area that had no scar at all. So we have included the intramural scars in the overall scar definition and only took the remote mapping points. And then we come up with two cutoff values. This was 3.0 millivolt bipolar voltage to delineate any post-infarct scar, also non-transmural scars, which are quite often in early perfused patients, for non-remodeled LVs, and 2.1 millivolt for remodeled LVs. And this is just one example showing the bipolar voltage of less than 3 millivolt. And here's any CMR-derived scar, so including these non-transmural areas. And you see already on eyeballing a good agreement, and we have, of course, analyzed the data. And this is shown here. So if you apply the adjusted cutoff value, so 3.0 for good function of the remaining myocardium, 2.1 for adverse remodeling, then we had a very good adjustment between the bipolar voltage scar area and any MRI on any LGE on MRI. So I think this is probably a good new adjustment to roughly get an idea where the post-infarct scars are. So I think in patients with primary myocardial infarction, MRI is nice to have for several reasons, but it's probably not something that we really need to do. It's much more complicated when it comes to VT substrate visualization. And if we talk about substrate visualization, we are talking about conducting channels, critical isthmus sites, diastolic pathways, and there's more and more evidence that many components of the RNT circuits are functional. So, but in the end, if you would like to image something, you need to know the morphological feature of what you want to image. And to date, there are only limited data on human data on VT substrates, and this is the work from Dr. Bakker, and I like this a lot because he has done VT induction in Langendorf perfused human hearts and has mapped this VTs. This is one example of a fast VT here showing an exit at the lateral wall and propagating around the ventricle and then the entrance here. And this is a diastolic pathway of the VT which you would like to target by ablation. And he has done a lot of effort to fix the hearts, stain the hearts, and this is just the slice with a return path based on mapping. This is one slice stained for severe myocardium and fibrosis here in yellow and red. So this is this 3D reconstruction of the diastolic pathway. So it has a width of 0.2 millimeter. So Pierre just commented on the resolution we have. So we would need to visualize this kind of area. We would like to visualize this return path, the diastolic pathway of this particular VT in this patient. And this is what we have. Pierre has already mentioned it. This is an isotropic MRI with a resolution of 1.4 millimeter. We can go down to 0.7 millimeter with a lot of motion artifacts. There are partial volume effects. So the noise to signal ratio is not very favorable. It's completely different. This is in a PIC model. This is an early perfusion infarct model where we gave in vivo LG, and this is ex vivo imaging, and then you have no motion, and then you get this very nice high resolution images which we would like to achieve, but we are probably not yet there in humans in vivo. So, but if we are not able to identify a circuit or a certain point in the circuit, we perhaps are able to identify areas that are associated with the VT substrate. And one important player is scar heterogeneity. And I really would like to spend 1 second on how these images are processed, because we all talk about border zone or gray zone or heterogeneous tissue, also when it comes to MRI processing. But this requires post-processing. And there are in general two methods to process MRI data for tissue heterogeneity. One method relies on the maximum density as a reference. So you take the very, very bright sky, and then you take a certain percentage of the signal intensity to define your border zone. Or you take the normal remote myocardium, and then you go to the median of this value or mean of this value, and then take a couple of standard deviation, and based on the standard deviation, you define your inhomogeneous tissue, or there are methods that use both. And this has been performed in patients with VT, and this is a group of Barcelona from Antonio Bierzo. We have spent really 10 years now on trying to identify VT substrate, in particular in post-MRI patient based on MRI. And this is isotropic MRIs, and what they did in the early studies, they have just took several slides to the wall thickness and then have color-coded the signal intensity based on the maximum that is shown here. It's 40 to 60% of the maximum signal intensity to define the border zone or the heterogeneous channel in the end. As they could also play a little bit, 5% plus minus for this border zone. Then they have defined a signal intensity channel as simply an area of relatively lower signal intensity in these compact scar regions, which had to connect to normal myocardium. And actually, they found a very favorable agreement if you compare these signal intensity channels with classic EP criteria. So if you take as a VT criteria your voltage channels, this was based on the bipolar voltage 1.5, 0.5 as heterogeneous or border zone voltage, or as late potential channels, then they found for 50% of these voltage channels or late potential channels a matching signal intensity channel. Then they also started to induce VT, and for some mappable VTs, they could localize the VT isthmus sites, and they were all located in a mapping-defined channel, and promising 73% of all were also located in a signal intensity channel. So I think EP still beats imaging, but these are very promising results. And they have more recently published a study where they have really used the segmented signal intensity channel, have loaded them into the mapping system and have focused mapping on this area where they found signal intensity channels. And this is a CMR guided. In those patients, they had MRI available but did not really use it for the mapping procedure. So if you compare these two, then they had a significant reduction in procedure time and fluoroscopy time. However, the acute success rates and the long-term success rates were not significantly different right now. So at the moment, we may state that we can use this to guide our ablation. If it really improves our procedure, this has to be shown. It's more complicated in non-ischemic patients, and therefore I've shown you this a little bit older data now from our lab, where we had the possibility to look at the whole heart histology of patients with DCM. The majority had this anteroseptal substrates we have heard about, and we were able to merge the mapping data with the histology data and could superimpose all our mapping points here on the original human histology. And I just would like to show you this fibrotic pattern, because this is typical in the DCM population. You see side by side more heterogeneous, you see this patchy pattern, it's completely mixed, but you never see channels. So we have done 3D reconstructions, but there are no viable continuous areas of viral myocardium connecting to something, and we don't see this compact scar that we see in post-infarct patients. And we had the chance to compare one MRI of a patient who had this MRI before we mapped him and before he unfortunately died after the procedure. And this brings me back to our reference MRI values. I have talked about normal myocardium as a reference or compact scar as a reference, but this patient, this was a maximum amount of fibrosis, and it was a minimum amount of fibrosis. So there was no normal myocardium and no compact scar. So we are completely losing our reference values for image processing if it comes to heterogeneity or channels in DCM patients. And we have just processed this MRI using the different methods. You remember this was based on the remote myocardium using the standard deviation method, which certainly underestimates fibrosis. This is 3, 4 here. This is a histology showing 50 or 27%, so it's completely missed by LGE MRIs. On the other hand, you can also overestimate fibrosis, like in this method here, where you see transmural septal scar, which shows this mid-wall fibrotic tissue in this example. So it's very important to know or to realize how these MRIs are built on and how they are processed. Also, if it comes to quantification of fibrosis, because it poorly depends on the method, and this also explains the different cutoff values that are used for voltage mapping, unipolar voltage mapping, because I will show you in the initial slides, the MRIs were processed according to different methods, coming to completely different results of the amount of fibrosis. So I would like to conclude. So the current role of CMR is very important in non-ischemic pathologies for the etiology and also to plan the access to replacement fibrosis. And this is what we think is LGE. I think the image integration, so having it available, the CMR during the procedure, is superior to mapping for mid-wall fibrosis. And I think post-processing is very promising. It can use as a first guide towards areas that contain the VT substrates in post-MI patients. And in my opinion, it's a very important research tool to better understand arrhythmogenic substrates in non-ischemic pathologies. So thank you very much for your attention.
Katja, wonderful session. Thank you to all the speakers. This is now open. I think we have time for, we'll take time for a few questions. We're late already, but we may have a couple of questions. So maybe, oh yeah, please.
Thank you very much. Very nice presentation. I have a question about the last session. So for Professor Zeppenfeld, how often in patients with non-ischemic VT do you don't find any scar on the CMR? And what kind of VT do you expect in this patient?
This is a very good question. I know you can answer the question because you have published on that, on the non-LGE VT ablation in non-ischemic. We don't see it very often anymore because we have this 3D isotropic MRIs. And sometimes in convention, this was the example I wanted to show you also. In this patient, we had an MRI from a prior center, and they simply missed the subaortic area. It depends on the scan, also on the slice thickness. So if you have a 10 millimeters slice thickness, you can, in particular perivalvular, you can miss areas. So therefore, since we have this image acquisition, and actually we look ourselves at the MRI, often the radiologists say, oh, there's nothing. And then you look subtly and you find something. So I think very often the first message is, in my opinion, very often we are missing it. So if you look carefully, it's very often there. We have a few patients also where we have VTs from the very basal LV, where I think it's very difficult because of the periannular situation. You always have fibrotic tissue there, and it's also difficult to delineate scar there. So in my experience, in our group, patients with no scar are not very common, but we do have them, and then it's very often, in my opinion, diffuse fibrosis in the septum, where you get very often very, very fast left bundle branch block-like VTs that may originate somewhere in the septum, and also something with slightly different morphologies, very often unstable. You have to calibrate them, and I think they are more due to this diffuse fibrotic pattern, very difficult to ablate. Yeah. Long answer for a short question.
Well, congratulations to both of you guys, Pierre and Katja, for your imaging. As you know, I'm not crazy for imaging, and so I think it's appropriate for me to challenge a little bit you guys, as I really support the primacy of truly functional electrical guidance and evaluation of what you have at the end of your day achieved with the ablation. But anyhow, let's go into a couple of specific questions. First of all, how do you trust the merge of a static figure, be that CT, be that MRI, they're wonderful, to the actual guidance, whereas you're fighting with the beating heart, where the margin for error is in the range of centimeters. So that is something that always has kind of kept me away from the true guidance. And something a little bit more specific, whenever we are dealing with epicardial non-ischemic substrates, what is being investigated and by the radiologist is this scar might be either related to prior myocarditis or to a initial left dominant rhythmogenic process. And I have never been able in my life to discern between the two, although of course on the prognostic standpoint this is completely different. So going back to that, do you think that sooner or later are we going to get a little bit clearer pattern in the discrimination of this type of disease entities?
Katja, maybe you take the second one, because you've been working on that.
So the second one is, so today, this is a very important question also for the prognosis of the patient and the handling, also for ICD implantation, yes, no, there. I think it's very important to really know the underlying diagnosis. And to date, I don't have the answer if there is a particular specific pattern which can identify post-myocarditis in patients without a clear history of that. Because this is a dilemma, right? So you see the patient has a scar and no typical history of myocarditis. So it's certainly not the active phase of the disease. We perform more and more PET-CT scans to see if we have still some inflammation there. But in the end, sometimes we just don't know, and therefore we have introduced this systematic genetic testing. And of course, there's also a group that is negative tested. Also, there's a family history, so also then we don't know exactly. But this should be, I know that you are very active in that really multi-center effort to collect MRI data, and you are doing that to see if we can find patterns that are more diagnostic or more specific for one or the other. Probably it's in particular we have really a subapical layer. This is perhaps more for post-myocarditis if you have more intramural, but I don't have the answer right now for that. Yeah, but I think it's a very important problem to solve. Yeah.
Registration, that's a very good point. It's not so difficult to have a good registration, but you have to make sure that it's good. So you have to check for the quality of your registration, which is not that difficult. I mean, you take your ablation catheter, it has to be magnetic, of course. You take it to remarkable area like the apex, for example, and you make sure that it's matching properly. Now, yes, there is a problem with beating heart and respiration, and I don't think it's properly addressed by navigation systems either. I mean, with your navigation system, you have your catheter that is, when it's in contact, it's moving with the heart, and you can follow that with the contact force curve very nicely as well. But your reconstructed magnetic anatomy doesn't move. So you're having a discrepancy here. Even worse, it doesn't move with respiration. In here, we're talking centimeters. The cardiac motion in the myocardial infarction, it's probably not that big, but respiration is, and it is not compensated for that, which is a mystery to me. I mean, it's been 25 years now that we have, or 20 plus years that we have navigation systems, and yet they have not provided us with some correction for that. And in addition to that, it gets even worse because if you have to cardivert the patient or if the patient moves because they are not always very comfortable during VT, then you're losing your accuracy. You may not even know that for sure. I mean, it's not quantified by how much, and you may have shift during the ablation that you're not even aware. And I think there are differences between systems here. Some are more strict than others to rise the alarm for a shift. But so nothing is perfect, and certainly registration is not perfect, and that's something we could probably improve. But navigation systems in the first place have their pitfalls.
Thank you. I was kind of told that we are really running very short, so I think there is one last question by Frank, and then we have to go to a coffee break.
So hopefully it will be quick, but just what is this now, the spatial resolution MR, especially as it relates to identification of epicardial scarring. And Daniele, can you tell us a little bit about T1 mapping and the future in terms, if you have a non-ischemic cardiomyopathy with depressed function, they have fibrosis. By definition, it's just not large enough to be picked up by MR. So where are we headed, and how do we identify thin layers of epicardial scarring that are missed by current technologies?
The problem is that we have an LGE-centric vision of CMR. So we think that if there is LGE, that's scar. If there is no LGE, there is no scar. But actually, the reality is what the Katja has shown, that especially in patients with non-ischemic cardiomyopathy, you have a diffuse fibrosis. And so your capability to detect LGE is based on a critical mass of substitutive scar that you can detect. So now we have some techniques like T1 mapping that basically considers the response of the tissue to the MRI field that can tell you voxel by voxel if there is some subtle change and can tell you if there is a diffuse fibrosis or not. But it's still the technology that needs to be improved because we have a lot of problems with the motion artifacts, and also is the center and sequence and machine dependent because there is not a cutoff. Every center has to develop their own cutoff based on the conditions you perform the examination. So it's something we still need to work on. And third thing, you have an idea of the presence of diffuse fibrosis, but right now it's very difficult to localize it in specific parts of the heart, okay? So you draw at the region of interest on the septum, and you can tell, yeah, maybe there is diffuse fibrosis, but to tell on a bullseye where the diffuse fibrosis is and where is impacting the VTs is very difficult to.
I think the imagers have to learn how to use their slider bar, just
exactly.
like we have.
And of course, we have data showing that in patients where the MRI is completely negative, or at least you cannot see anything, then the voltage mapping is able to detect because it's more sensitive.
Absolutely, and that slider is the same for LGE. I mean, radiologists are making the images, choosing the definition, and then adjusting according to what they think is the reality. But and CT is very different with respect to that because it's calibrated on water. Water is the same in your place and in my place. So there's no, I mean.
If photon counting is like we don't have it, but I saw the images in meetings and whatever, but if those are the images, probably MRI is over in what,
No,
10 years?
I don't think it is over, but it's a very exciting, I think, revolution in the field of imaging. Yeah. Well, I think it's time to conclude. Thank you so much.
Excellent
Joseph,
session.
at what time should we come back?
20 minutes from now.
20
I was
minutes
told
from
that
now.
Our coffee
Perfect.
break is a little shorter.
Enjoy the coffee break.
Congratulations
Thank
for
you.
the excellent talks.
I like the presentation. It was very nice.
Thank you.
Yeah, really nice.
Thank you.
Yeah.